Today we are talking about what's new in regenerative medicine. And this is our first webinar of the year, a little bit late in February, but looking forward to doing this for the rest of the year as well. Great. And as I'm talking, please enter your questions and I will answer from time to time as time allows. If there's any questions or any challenges with hearing what I'm saying or seeing what I'm talking about, please just message that into the chat. And as a reminder, after we're done today, this is being recorded. If you start recording, this is being recorded and you will have access to watch this later on as well. Okay, great. So in today's talk, we're talking about a few different things when it comes to regen med concepts, indications for treatment, some technique things that are worthwhile for you to know as patients, complementary treatments that may be helpful, even some regulatory and insurance things. Again, if any questions afterwards, you can always contact us via any of our social media sites, as well as our website at chicagoarthritis.com. So briefly about who I am. My name is Siddharth Tambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology and regenerative medicine. In practice since 2008, involved in regenerative medicine since 2008, and in the Regenix Network since 2012. The Regenix Network is the largest group of physicians who are collaborating and working together in regenerative medicine, sharing best practices and ideas to help our patients get better results. So let's talk about some basic concepts or key concepts that you really need to understand about regen med. Our goals here are to treat the root cause. And the root cause for most joint issues comes down to either instability or inflammation. Instability meaning that there's been some previous injuries of soft tissue structures, and now you have some chronic instability, looseness around the joint that then causes more pressure on the joint or tendon, which eventually causes arthritis, tendonitis, and other issues. Inflammation, which can be because of chronic instability, but inflammation can be its own thing. It can be an autoimmune issue. It can be a metabolic issue. It can be a few different reasons why a person has instability. Those two key concepts makes up the vast majority of what we're seeing when it comes to pain. Obviously, there's other issues that can be occurring, whether that are nerve-related issues, spine-related issues. If you have other types of endocrine issues, that can sometimes cause pains as well. But instability, inflammation are generally the two key things. Our goals are to be disease modifying. And what that means is treat the actual cause of your problems, not just suppress your symptoms. Important because the traditional way of treating joint and tendon issues has been more about just suppressing symptoms, either medications to treat pain or injections like steroid injections to reduce pain, and not really treating the root cause of the problem, which is, again, instability and inflammation. So we're going to talk about some key regen med concepts that are really relevant when it comes to how we treat people. Stability is really the key one here, especially with osteoarthritis and tendonitis. There is this concept in architecture called tensegrity. It means that if you take individual units that are weak on their own, if you put them in close approximation and then compress them, you have an overall structure that is much stronger. And you see this in everything in architecture, whether it's buildings, bridges, really everything. So the same concept applies in the body, and that's called biotensegrity. So prolotherapy is the idea that if you have someone that has some instability around the joint, if you would inject your own cells or other fluid into those soft tissue structures, and you treat all the layers of depth that are damaged in that area, in that joint or tendon, then you can get a progressive strengthening of that joint over time that generally will not only improve function, stability function, and then pain and inflammation, and will generally give longer lasting results as compared to most of the other treatments that are typically done non-surgically for arthritis and tendonitis. So how do you treat instability? It's a few different things. Do the right strengthening exercises, optimize your weight if it's above where it needs to be, and then utilizing prolotherapy, orthobiologics, which we'll talk about, to strengthen ligaments, tendons, and other soft tissue structures around the joint. Things to avoid. In the past, you had a lot of routine surgeries that primarily cut out tissue. That still kind of happens. And in someone that already has wear and tear arthritis, the problem if you're doing, let's say, knee arthroscopy, for example, is that if you already have arthritis, trimming up the cartilage is not fixing the problem. It's actually accelerating the instability because now you have less structure and tissue to help support the joint. So in most people, that is no longer recommended. Steroid injections are another really common kind of treatment that's done. In wear and tear arthritis, the issue is that if you do it too often, you can weaken and damage cartilage and soft tissue structures. A lot of times, your physician for pain relief may be injecting a high concentration or volume of local anesthetics that can give pain relief but can also degrade cartilage long term. You may hear about radiofrequency blocks or genicular artery embolization. These are other types of injections that, in particular, interventional pain and interventional radiology will do for sometimes joint issues. The problem is that frequently it'll end up damaging nerves that you need for either muscle control or for sensation around the joint. And as you damage those kind of nerves, you now have joints that are typically less stable and less really stable in movement in space. It's called proprioception. So prolotherapy as a concept means that we strengthen the soft tissue structures around the joint to optimize the functional unit to overall improve function and pain. As a treatment concept, dextrose prolotherapy is where we take a concentration of sugar water and inject that into those ligaments. That is the original regenerative medicine treatment that's been around since the 50s or since the 50s. It's a milder treatment. It can help. It generally takes multiple treatments. A more advanced version of these are when we use your own cells, either your own blood platelets or your own bone marrow stem cells. Let me just pause for a moment. Okay, great. So how do you treat the inflammation component that you see in arthritis conditions? So there's a few different things you have to keep on. Number one is, do you have inflammation from a metabolic problem? So let's say you have insulin resistance. We know that can be connected with inflammation. We know obesity can also be connected with inflammation. The actual fat cells excrete what's called adipokines that can cause inflammation. So we know that improving your metabolic health can actually improve your inflammation. So generally, what I'll suggest is on a metabolic level, an anti-inflammatory nutrition diet, very low risk, can be helpful. Weight loss if needed. GLP-1 agonists, that includes things like semaglutide, tirzepatide, Wegovy, Ozempic, Zepbound. They not only help with weight loss, they help with metabolic health. And there is some early suggestion that they can help with inflammation as well, because they're helping out with your metabolic health. Now, if you have inflammation from other types of conditions, let's say rheumatoid arthritis, psoriatic arthritis, that has to be treated appropriately. That's a little bit different, but that still needs to be treated appropriately. Now, in a arthritic joint that's chronically unhealthy, you could have some chronic low-level inflammation that causes swelling. Utilizing orthobiologics, you can optimize the cells that are in a damaged joint or tendon. That'll then reduce inflammation, improve strength, which will improve pain long-term. Steroid injections, on the other hand, which will help inflammation short-term, but can actually damage some of those cells longer-term, and can leave that tissue more irritated and inflamed longer-term, which is why we try to avoid steroid injections in wear and tear arthritis situations. So regenerative medicine is the process of using your body's own cells to treat your arthritis, tendinitis, injuries, and back pain. This utilizes the body's normal healing process. If you think about how the body normally heals after an injury, take something as small as a cut on your finger. You have cells that come into the area, platelets specifically. They first stop the bleeding. They then release growth factors, which then stimulate your local stem cells. Those stem cells then start by coordinating and bringing in other cells that then start a normal healing process. So in tissues that have good blood flow, let's say the skin, the body tends to heal very well on its own. In tissues where blood flow is not as robust, that can include tendons, cartilage, ligaments, discs, labrum, menisci, they may be hardy tissue. The problem is that if they get damaged or chronically irritated, then they tend not to heal very well on their own. So regenerative medicine is the process of taking those same cells that are involved in this healing process and injecting them into the tissue that's been damaged to help coordinate that normal healing process that you would normally get. So again, why regenerative medicine is going to treat the source of the problem, which in most people is instability and inflammation, certainly safer than surgery. It's effective for most musculoskeletal conditions. There are a few things it's not. We'll talk about that. And 80% of traditional orthopedic surgery will eventually be managed by regenerative medicine. In the same way, the vast majority of what used to be handled via open heart surgery is now handled via needle-based procedures and medication when it comes to cardiology. So orthobiologics, these are the biologic cells and tissues that we extract and then re-inject into your tissue that's been damaged. Again, it utilizes that normal healing process, and I strongly, strongly recommend using your own cells versus someone else's. And the reason why is almost all the data that's ever been published in the world when it comes to arthritis and tendonitis and utilizing regenerative medicine comes from using your own cells. There's minimal to almost no data when it comes to using somebody else's. There's additional risk when you use somebody else's. It may sound appealing that can you use somebody else with healthier cells. The thing is, if it's not from your own body, there are potential risks in injecting somebody else's cells. So when it comes to regenerative medicine treatments, there's a few different things that we'll utilize that are legally allowed in the United States. And here's a sense of how we'll utilize them. There's dextrose prolotherapy. Again, that is kind of our mildest option, the one that's been around since the 1950s. Generally, it's getting a monthly treatment for anywhere from 3 to 6 treatments. There's using with progressive improvement with each treatment, giving a longer lasting result. There's platelet-rich plasma, where we'll end up repeating treatment every 6 to 12 months, depending on how you're doing, to get you to a higher steady state. Then there's bone marrow-derived stem cells, where one treatment will generally give people good relief for 2 to 5 years. If you have more advanced arthritis, you may need a platelet booster at some point down the line. And there's adipose, that means your fat cells. There are some very strict FDA rules to this. You can use adipose to augment your platelet and bone marrow treatments, namely as a structural support, as opposed to a standalone treatment. So let's talk about some of these different orthobiologic treatments. So platelets or platelet-rich plasma is probably the most used one right now. Again, platelets are important because they really kickstart the normal healing process. You get inflammation that is instigated by platelets to begin with, which starts a normal tissue repair process. Platelets work because they stimulate your local mesenchymal stem cells. There's different types of platelet preparations. The key thing to understand is that your physician and the office needs to have enough nuance and a approach to your care that is bespoke and personalized so that they can alter the type of cells that they're using. Meaning there's different ways to prep platelets. You can make it into different types of concentrations depending on what tissue needs to be treated, joints, tendons, or ligaments, or nerves. They can make versions that have cell bodies, ones that don't have cell bodies, ones that have red blood cells, ones that don't have red blood cells. There's a lot of variability here, and it makes a difference because different tissues respond differently. If you get a one-size-fits-all approach, you're not going to get an ideal outcome or an ideal approach to your treatment. So strongly recommend working with physicians that have this nuance when it comes to platelets. Platelets are great as a first-line option for generally mild to moderate conditions, sometimes can be helpful for more advanced conditions. If you end up using it for a more advanced condition, understand you'll likely need additional treatments to get a higher level result. Next, you've got your own bone marrow-derived stem cells. Stem cells or mesenchymal stem cells are the main cell that drives tissue repair and recovery after an injury. please use your own cells. That's what's legally allowed and required in the United States. Bone marrow-derived stem cells are what's legal in the US. Fat stem cells, because in order to isolate the cells from your own fat, you have to use an enzyme that the FDA does not think is safe in humans. Fat stem cells, specifically speaking, are not legal in the United States. You can, however, use fat and adipose for structural support, and do encourage that in people that have significant tendon or ligament injuries where that can be helpful. You may hear about amniotic or umbilical cord cells. You probably don't hear as much about it nowadays. And the reason why is because there's no living cells in those products. And if clinics or vendors are advertising this as a stem cell treatment without living cells, the FTC has come and sort of squashed that. So I would try to avoid those. Use your own cells. You may hear about IV stem cells in other parts of the world. Not legal in the United States, no proven benefit for orthopedic conditions, may help with temporary inflammation, but beyond that, I would be cautious in terms of its utility for arthritis and tendonitis. So how do we decide when it comes to a region med treatment? Number one, how do we decide if you're a candidate? How do we decide on what treatment to use? Number one, we look at what is your issue, like what joint are we treating? What's the severity of the issue? Do you have any other medical issues that can make one treatment or another treatment a little bit more challenging? And is this a initial treatment or is it a booster treatment? Booster treatments are generally not necessarily quite as aggressive as the initial treatment. They're meant to kind of keep that initial treatment going. And then, of course, cost. Most of these treatments are out of pocket. And of course, cost can be a consideration as well. When it comes to outcomes, when it comes to bone marrow stem cell treatments, yes, we are able to improve pain and function even if you have advanced cases. Can we improve how your imaging looks? If you have advanced arthritis, cannot necessarily improve how the imaging looks. That's just not possible based on current medical science. On the other hand, if you have a tendon tear or ligament tear that's still small, that can actually improve on imaging. I'll show some examples of that. If you have swelling in the joint, reducing the chronic inflammation can definitely occur longer term. And if you have damage in the bone, if it's not advanced, if it's still in an early enough stage, we can actually reverse that as well. So there are things that can be reversed, things that cannot. The main outcomes, however, are still how do we improve your pain, function, and keep you healthy? Again, if any questions, please just jot them into chat. And actually, let me just quickly check to make sure there's no questions coming via any of the social sites as well. Okay, good. Some other key things that you really definitely need to understand when it comes to these treatments include the following. So, interventional orthopedics. This is the idea of utilizing image guidance to treat all orthopedic tissues or injuries. This is key because the old school way would be to just palpate the area and then sort of stick the needle into where you're hoping it lands. The problem with this is, number one, nobody has X-ray guidance. So to a large extent, they are guessing. And number two, when you are treating very small areas of damage, you need to be even more precise. So picture that's up there is an ultrasound image showing a rotator cuff and a needle. That's the kind of thin white line injecting into a very small dark area at the bottom or in the middle of the screen. That is a small rotator cuff tear. This is a zoomed in picture from an ultrasound. So that is a 1 millimeter by 1 millimeter spot. You cannot hit that reliably if you're not using image guidance. The next picture on the right is of an X-ray of the shoulder, where now we're injecting into the shoulder joint. Key thing here to understand is that sometimes people think they're hitting the shoulder joint when they're injecting blindly. It's not as simple as it is actually. Like, to actually get it into the joint proper and then inject cells, you have to be very precise. The other interesting thing about this picture is that besides the black line that's within the joint. You also see a little triangular line that's injecting into the labrum. You cannot reliably hit some of these structures if you're not using image guidance. Important because as opposed to steroid injections, if you inject somebody's ear, you could probably get a benefit in their toe just because there's an overall effect on the body. That has a lot of side effects long term if you have that kind of systemic effect. When it comes to injecting your own cells, you have to be dead on and very precise. You cannot do this legitimately and reliably without that kind of image guidance. These are pictures of into the knee. The one on the left is into a patellar tendon. Again, using image guidance to make sure we're hitting the right exact spots of the tendon. Picture on the right is of an X-ray image as we're injecting into the ACL. The ACL is a very deep structure in the knee. In order to hit that accurately, you really, again, have to use X-ray or fluoroscopic guidance to make sure you're hitting the proper structure. You cannot do this blindly, and you can still help people out if you do this properly. So what are some indications for regen med? So most osteoarthritis conditions, if you have failed physical therapy, can still be treated with regen med. This includes if you have more advanced knee osteoarthritis or lower back arthritis. Some exceptions, if you've got more advanced hip arthritis, generally tends not to respond as well to regen med, in which case hip surgery should be recommended. Most tendonitis conditions can be treated. Even if you have a full thickness tear, as long as the tendon or the ligament is not fully pulled apart, it's still closely approximated, that can still be treated. The exceptions are if your imaging reports that you have a retracted tear. Retracted tear means that the two ends of the tendon to the ligament are not next to each other. They are literally pulled back to the bone, away from each other. That needs surgery. Post-surgery, they should still put some bone marrow cells into that to help prevent a re-tear in the future. What about ligament strains? Absolutely. Again, the exceptions are if you have a ligament that is so badly torn, it's fully retracted. That we cannot necessarily help with, but otherwise strains where the ligament is still generally intact can still be benefit from treatment. If you have a pinched nerve, that can include a pinched nerve in the lower back, like sciatica, a pinched nerve at the wrist, pinched nerve at the knee or the ankle. Again, exceptions would be if you have more significant weakness, which can indicate that you've had such significant impingement of the nerve that surgery probably would make sense. And then, of course, what about other indications? What about inflammatory arthritis, conditions like rheumatoid arthritis or psoriatic arthritis? As a rheumatologist, I see a lot of these patients. My general recommendation, if you have an autoimmune condition like that, is get the autoimmune condition under control first. If you have one or two joints that are still chronically, let's say mildly inflamed, then consider regen med for that. Or if you also have wear and tear arthritis, which is very common, overlaid on top of inflammatory arthritis, you can still treat the osteoarthritis, the wear and tear arthritis. Generally, I recommend timing is that you should control the overall inflammation in the body first before you go on to using a regen med treatment so that you get the best result. When do you treat? That's another important question. The old school thinking is wait till your symptoms and condition are advanced. The problem with that is that when it comes to your joint health, waiting till your symptoms and condition are advanced is the equivalent of saying somebody has high blood pressure. Why don't you wait till you've had your first heart attack, stroke, or kidney failure episode? That doesn't make sense for those other organs. It doesn't make sense for your joints or your tendons. You should be getting these areas treated properly. So I think a more appropriate modern way to think about your joint health is get treated conservatively. Again, maximize your weight, over-the-counter supplements to reduce inflammation, the right kind of nutrition, get into physical therapy, do the right kind of strengthening exercises, do all that. If you're failing conservative treatment, you should consider a disease-modifying concept, and that would include the regen med treatments. And if you've had an injury, if you're recovering quickly, great. If you're not recovering quickly, then you should consider a regen med treatment to help you longer term recover more adequately. Other things to know about treatment, Repetitive treatment can be added. What do I mean? There's a stair-step effect. Generally speaking, what happens after Regen Med treatment is that there's short-term a bit of inflammation, you're noticing improvement, and then at some point you'll start to plateau. And if you do a second treatment, you're now building off that higher plateau level, in which case now you're stair-stepping to the next level. When it comes to treatments like prolotherapy, we recommend doing monthly treatments because they're milder and doing that 3 to 6 times. For platelets, I generally will treat and then see how people do for the next 6 to 9 months before considering another treatment, because I know there's a slow progressive improvement. For something like bone marrow stem cells, I know you'll get a benefit for 2 to 5 years. If we need to do a platelet booster, generally speaking, you'll do that after about 1 year to 2 years, if needed. Not everyone needs that. Also understand that chronic osteoarthritis can be treated chronically. What that means is that because these treatments help to improve stability, reduce inflammation, they are what we call disease modifying, preventing a condition from progressing. Important because let's say you have knee arthritis and somebody says, well, eventually you're going to get surgery. Eventually you need a knee replacement. That's not always true. If you can improve stability, control inflammation, keep you physically active, and keep you overall healthy because you're physically active, then you can treat this in a more chronic manner without having necessarily to be doomed to go to surgery. And then, of course, understand that fixing the problem means optimize and maximize it, right? We cannot reverse time here, right? We cannot say someone who's got chronic arthritis in the knee or the back for decades that's been progressive, that we can flip you back to when you were 18 years old. Nothing can do that. Even surgery, if you get a replacement, cannot do that. You're just amputating the joint and putting in a prosthesis. So nothing can reverse time at this point. What we can do is optimize the joint, improve stability, improve inflammation, get the joint to be as healthy as possible so that you can be more physically active, living with less pain, and living a better life. So we can optimize and maximize. That is what we can do here. Other keys when it comes to Regen Med, this is something you have to really be aware of when you're working with your physician. Number one, they have to treat the whole functional unit. So as an example, let's say you've got knee arthritis. If they're only injecting to the knee and not treating the rest of the functional unit, all the other soft tissue structures, they're missing an opportunity to give you a better result. They should treat all the sources of pain and the root cause of the problem. Again, that means treating instability, treating inflammation. If needed, let's say you have instability or problems above or below the joint that's most problematic, they should consider treating that as well. Classically, let's say you have knee arthritis pain and you have a little bit of lower back pain. Well, it may be worthwhile to address the lower back at the same time because that could be contributing to the instability and pain in the leg as well. And then in that same vein, treat the neuropathic causes. Again, if you've got a pinched nerve in the back, worthwhile treating that because if the nerve is causing pain, that should be treated. And we have Regen Med treatments that can help with that. Alternatively, if a little bit of nerve irritability is causing some weakness in the leg, that could also be contributing to some of the instability and problems as well. And you want to treat the nerve issue as well. Some other things to keep in mind, what we've come to understand is that in people that have moderate to more advanced arthritis, including for things like the knees, the hips, the ankles, the shoulders, that treating the bone itself can be very useful and actually give a better result. Over time, we may be doing that for more significant tendinitis as well. There's some thinking that this might be partially disease modifying in that when you think about what's going on in the bone, you have stem cells in the bone that are supplying nutrients, blood flow to the cartilage as well. And so if you can treat that part of the organ system, right, you have a chance to give a more profound result. These are more newer concepts, but progressively we are starting to move in that direction. Dosing matters when it comes to treatment. High dose of platelets, high dose of bone marrow. So how does this come into play? A low dose generally gives lower results. So let's say your physician says they're going to treat your knee and they want to give you a platelet injection once per week or once every 2 weeks for the next 3 weeks. That is an old style way of treating where they're using a low dose of platelets. It does not give a better longer term result. you're better off doing a high dose of platelets in one treatment to get a better result long term. And then try to optimize your general health as well. So your joints are part of your overall body. They're part of your overall metabolic health, your hormone health, muscle strength as well. So if there's things that are overall off in your general health, as much as possible, try to optimize that before, during, after your Regen Med treatment as well, in order to get the best outcome. Because your joints do not sit in isolation, they do sit as part of your overall body and health as well. Excuse me, just quickly checking to see if there's any other questions to address. Okay, good. Complementary treatments. What else can you use that can be helpful in Regen Med? Look, there's a lot of different options. I think anything that is low risk, complementary, not damaging tissue is worthwhile. Chiropractic can be helpful. Just make sure you're working with someone who's experienced. If you have significant instability, be careful with chiropractic. You don't want to do things that exacerbate instability. Massage can be helpful. Dry needling can be helpful. Acupuncture can be helpful. Red light therapy can be helpful. Shockwave can be helpful when it comes to tendons and ligaments and myofascial tissue, all of which contribute to joint pain as well. Peptides, interesting. You probably hear about peptides a lot. There's probably some benefit in peptides short term. There's almost no data on using peptides, all right, around the time of Regen Med treatments. In theory, they may be helpful in terms of improving blood flow. A couple things. Number one, limited data to commit to peptides, but kind of in theory makes sense. Number two is you have to be careful because sometimes what may be healthy and helpful short term, like some peptides, may have an issue long term, meaning if you're taking it for prolonged periods of time. So as an example, things like BPC 157, TB 500 are frequently used for joint issues. I think after an acute injury or maybe after a procedure, maybe there's some benefit to that in theory. Again, very little data on this. Long term, if you're using this for pain relief, let's say for many months to years, there may be potential issues in theory that you should be aware of because some peptides can increase your VEGF levels, which is a growth factor that is needed for blood vessel creation, generally a good thing, but can also be connected with cancer as well. So you just have to be aware of some of the potential risks here and work with physicians that are thinking about this as well. Regulatory issues. Look, this may seem a little bit odd for the general public to be thinking about this, but you need to know about this because it affects the kind of treatments your physicians can offer. This is a dynamic environment. Treatments like platelet-rich plasma and bone marrow stem cells for orthopedic and musculoskeletal issues is pretty well vetted at this point by the FDA. It is allowed if you're following some very clear cut criteria. That includes using your own cells, using it for orthopedic conditions, and when the cells get drawn from you, they need to be prepped and re-injected the same day without significant manipulation. Adipose or fat can be used for structural issues, cannot use some of the other enzymes or chemicals that in the past were used. Birth cord fluid treatments, that includes amniotic and placental cord treatments. They're not allowed for musculoskeletal conditions. You may hear about them being used a lot less because the FDA started to come down on clinics who have been doing this. Again, there's no living cells in those treatments. Exosomes are an idea. They're basically the growth factors from stem cells that get released. Again, it's an interesting idea. But again, they're sort of foreign products. There's almost no data on these treatments and still not approved for musculoskeletal orthopedic use. So be cautious if that's being pushed to you. They may not be aware of the regulatory issues and they may not be aware that there's almost no data on how well it works. Stick with the things that are proven, that have been tested, your own platelets, your own bone marrow at this stage. Insurance coverage. Look, these procedures are generally not reliably covered under insurance. The exceptions, if you work for a large company that is self-insured, they have the option of adding whatever they want to their benefits plan. So regenxcorporate.com is a insurance benefits sort of solution if your company can offer these kind of treatments. And so probably a third to maybe almost a half of our patients nowadays come from companies where these procedures are covered through their insurance plan. Again, if you want to learn more, please go to regenexcorporate.com. For the vast majority of people, this is still mainly an out-of-pocket cost. And to get it done correctly, you have to do it correctly. There's right and wrong ways to do these kind of treatments. Make sure you're working with physicians and clinics that are focused on doing this correctly. If interested in getting evaluated, you can email, call us, write to us on any of our social sites. You can contact us at chicagoarthritis.com. We are here to help, and we're here to help guide you in the right direction. Wonderful. Okay, here's a question. All right, somebody talking about or someone they know is 80 years old. They've got rheumatoid arthritis. They've got degenerative right hip. More and more difficulty with ambulation. They want to know if there's any chance Regen Med can help. They do not want to consider hip replacement. Depends on the severity of your hip arthritis. Depends on how well controlled your RA is. So if your hip arthritis is more advanced, then generally speaking, I would recommend hip replacement. If you're really dead set against hip replacement, and if you have more advanced hip arthritis, again, hips are the one exception, more advanced hip osteoarthritis, then your chance of getting a good result is probably a 1 out of 3. Right? So it's a harder treatment in that case. Okay, good question about risks associated with PRP treatment. What's the success rate if you have more advanced arthritis? Good questions. So when it comes to risk, these treatments are generally low risk. And what that means is that anytime you stick a needle into the body, that can be for an injection, that can be for a blood draw, it can be for a flu shot. There's a low potential risk for bleeding, infection, tissue damage, no response. How do we minimize those? Bleeding risk, you minimize it by using image guidance, X-ray and ultrasound guidance. Make sure you're hitting the right tissues, not hitting the wrong tissues. Make sure you're not causing any damage. Infection risk, using fairly standard medical sterility protocol to reduce or minimize the chance of infection. It's very low risk. And then picking the right people who you think can benefit. You've got more advanced arthritis of the knees. Here's how I'd recommend thinking about this. Platelets can still work. You should mentally expect that you may need a repeat treatment a little bit sooner. That might get 3 months, might get to 6 months. Bone marrow is likely a stronger and more reliable option, but platelets, if you layer them in a couple times, can still give a very good result in knee osteoarthritis. Knees are remarkable in terms of how well they can do with treatment, and it's sort of the exception to the rule in the sense that more advanced arthritis can be a limiting factor in some joints, in particular the hips, but in knees still respond pretty well. And what that means is even if you have more advanced arthritis, the average improvement with these treatments is roughly 65 to 70% at the 1 and 2 year mark when you're treating knee osteoarthritis. So still a very treatable area, and one that is remarkable in that how well they can still respond to treatment. So I think platelets are a good, decent option for you to consider. Okay, wonderful. Any other questions at this time before we wrap it up? Again, as a reminder, you'll get a review of this, assuming we tape this appropriately. I think I hopefully did that correctly. And you can always contact us at any time afterwards, either for evaluation, other questions, or anything else that we can help out with. Thank you, everyone, for your time. Until we can, okay, hang on. One other question. Okay, somebody asking a very specific question about medications. This is very much a person-to-person question. When people have more other medical issues, right? What we try to recommend is, number one, try to make sure those other medical issues are as optimized as possible. So in this person's case, they asked about blood thinners and prednisone. If you're on blood thinners, it's just a matter of holding it around the time of treatment. All right. So we deal with that pretty commonly, as long as that's coordinated with your prescribing physician. That should not be a problem. Prednisone, it's a little bit more complicated. Generally, I recommend to people, if you're on high doses of prednisone, high doses, then get your overall condition under control so you can reduce your prednisone, so then you can proceed with treatment. In theory, prednisone can reduce the effectiveness of treatment. In my experience, in patients that have certain other autoimmune conditions, sometimes they can't really fully get off the prednisone. I've still had pretty good response to these treatments. I still will caveat, right, treatments in those folks who are on prednisone, that it may limit the effectiveness of treatment. But I think you have to ask, why are you on the prednisone? Is it short term? Is it long term? Are there other meds you could be on to help reduce the prednisone? All that kind of stuff. If you can do so, that is preferable for your treatment. Okay, wonderful. Thank you, everyone, for your time, for the questions and the engagement. Until we connect again, everyone, have a good day and live well. And until next time, talk to you later. Bye-bye.